Thank you, and good afternoon. I'm happy to be joining you today to discuss some current issues and topics in the Illinois community system of services for people with intellectual and developmental disabilities. Let's take a look at the topics we'll be discussing today. We'll start with a brief overview and status update on the Home and Community-Based Services, or HCBS Settings Rule, and the accompanying topic of the Illinois State Transition Plan, or STP. We'll discuss some issues related to employment, including federal legislation, as well as a current effort underway here in Chicago. We'll move on to the latest consent decree and some current activities related to that. We'll also talk about the status of the recent rate increase for community services, including some direction that was just issued by the state on Friday. I'll update you on the rate study underway, and finally share some research we've been conducting on people in community integrated living arrangements, or CILA settings. I'll save some time at the end of the webinar for questions, so feel free to submit them throughout the webinar. Let's talk a little bit about the HCBS Settings Rule, starting with the intent of the rule. In 2014, the Centers for Medicare and Medicaid Services, or CMS, which oversees the Medicaid program that funds most IDD services across the country and here in Illinois, finalized a rule governing the Medicaid waiver program. Here in Illinois, the Medicaid waiver program funds community integrated living arrangements, or CILA services, community day services, which were formerly called developmental training, or DT, some supported employment, and home-based services, which is a program in which people have authorization for a monthly allocation they can use to either purchase services or pay somebody to provide them with direct services. CMS's expectation is that these kinds of community services are distinct from other Medicaid programs, such as intermediate care facilities for people with developmental disabilities, or ICFDDs, in that people in Medicaid waiver-funded programs should live their lives and experience the community in the same manner as people not receiving HCBS-funded services. The intent of the rule was to provide clarification and direction to states regarding CMS's expectations for using Medicaid waiver dollars in community settings. The rule had been in development for a number of years before being finalized in 2014, with ample opportunity for stakeholder input. Let's take a look at some of the highlights of the rule on the next slide. So here are a few key topics addressed in the rule. First, the rule states that settings in which HCBS services are provided should be integrated in and support full access of people receiving Medicaid HCBS to the greater community, including opportunities to seek employment and work in competitive integrated settings, engage in community life, control personal resources, and receive services in the community to the same degree of access as people not receiving HCBS Medicaid services. So really what CMS is saying is that the expectation is that the Medicaid waiver dollars should be assisting and supporting people receiving those services to live the same kind of lives as you or I or anybody else not receiving HCBS services. The setting should be selected by the person from among setting options, including non-disability specific settings. The setting options are identified and documented in a person-centered plan and based on individual needs and preferences. The setting should ensure that a person's right to privacy, dignity, and respect, and freedom from coercion and restraint. The setting should optimize and not regiment individual initiative, autonomy, and independence in making life choices, including but not limited to activities of daily living, the physical environment, and with whom to interact. And the setting should facilitate individual choice regarding services and supports and who provides them. So CMS with the rule really was establishing a framework for the delivery of community-based services and really clarifying their expectations to states for how they expect Medicaid waiver dollars to be used. So let's move on to the next slide, which details some of the requirements for residential settings. So CMS outlined 5 requirements for residential settings, as well as a detailed process that must be followed if one or more of these requirements cannot be met for health or safety reasons. So in service delivery, we would generally think of those as quote unquote a rights restriction. The 5th requirement regarding accessibility cannot be waived for any reason, but also does not require universal ADA accessibility for all HCBS residential settings, only those where somebody receiving the services requires accessibility. Here in Illinois, and really across the country, there's some question as to how well residential services reflect these requirements. So for example, going through the home settings requirements, the first item is that the person must have a lease or legally enforceable agreement providing similar protections. And very specifically, the protections that CMS was wanting to assure were available to HCBS participants was that if something happened with a service provider, the person would not be forced to leave their home setting and would be able to continue living where they had been living. In Illinois, generally speaking, some folks do have leases, whether with a provider organization or in some cases lease their own settings as well. Many people have some sort of an agreement or a contract of some sort, but really the legally enforceable element of that agreement is what was essential to CMS and is essential for provider organizations to assure. The person should have privacy, including lockable doors, choice of who they live with, and the opportunity to furnish or decorate their own unit. The person controls his or her own schedule, including access to food at any time. It's interesting that CMS actually put that language in the regulation. They were quite clear that the expectation is just as you or I have access to anything in our home whenever we want it, these are people's homes and they should have access to food at any time they want. The person can have visitors at any time. Again, this is language directly from the rule. This is an example where, for example, if a setting had quote unquote visiting hours during which people could have folks come but was limited to those hours, that would suggest probably a conflict with the requirements of the rule. And then again, the requirement for physical accessibility. This is the one requirement from the list of 5 that cannot be waived. If there was some issue with one of the other requirements that for some reason could not be available to a person, again, in the rule, CMS laid out what I would call a quite elaborate process and an ongoing process that must be undertaken to demonstrate that indeed there is some risk to the health and safety of the person if that requirement was available to them, but also that there is a pretty involved, I guess I would say, process to try to help the person be able to move beyond that restriction. So the access to food is an example. For example, just because a person has a medical condition, say diabetes, that would not be sufficient justification to say the person couldn't have access to food at any time. You would, if you were going to limit that, would have to demonstrate that through the HCBS services the person was receiving, there was an effort to help him or her be able to make safe and healthy choices, maybe joining a diabetes support group, education, some examples of things that would be expected to have been tried before the more restrictive limitation was put in place. And that, again, is more directed than currently exists in HCBS settings. So we're going to go on to talk a little bit about the idea of settings that isolate. So another provision within the rule was developing the process called heightened scrutiny, which would be applied to certain types of settings that CMS believed were unlikely to meet the settings requirements. There's been some modification to the above guidelines since the rule was first issued, but the process of heightened scrutiny remains a requirement for states to demonstrate that they are closely reviewing HCBS settings to assure they reflect the community nature expected by CMS. So CMS originally identified a few examples that could constitute settings that isolate. And when they say isolate, what they mean is isolate the person from other people in the community. So if the setting was designed specifically for people with disabilities, and often for people with a certain type of disability. Now, interestingly, when we look at that concern or consideration, we recognize that in the Illinois HCBS system, then SILA settings would meet that definition. They are specifically designed for people with intellectual and developmental disabilities, and that is a red flag for CMS. The individuals in the setting are primarily or exclusively people with disabilities and the staff that provide services to them. Again, that is another feature of the SILA program in Illinois. Now, certainly there are some folks who have family SILA or who live in intermittent SILA, but the vast majority of the approximately 11,500 people in SILA settings in Illinois are in group home agency-controlled residential settings. The setting is designed to provide people with multiple types of services and activities, including housing, day, medical, behavioral, therapeutic. That could describe some of the HCBS settings in Illinois. It's not necessarily descriptive of all of them. People have limited interaction in the broader community, and settings that use practices that are institutional in nature. Those would all be examples of concerns that CMS would have that the setting is not promoting full inclusion and access and participation in the community. So the heightened scrutiny process is still being, I would say, worked out. CMS issued some recent guidance on heightened scrutiny because there was a good deal of confusion and concern across the states, certainly not limited to here in Illinois. The process remains that it's a state function to evaluate settings initially and then submit that setting finding to CMS. Also, the process by which a setting is determined to isolate has to be approved by CMS as part of our state transition plan, which is something we're going to move on to in a minute or two. So another topic addressed within the rule is conflict-free case management, which is described on this slide. Conflict-free case management wasn't a new provision of the rule, but CMS felt the need to clarify expectations and basically said, hey states, as long as we've got your attention with this rule, we're going to remind you of our requirements in a few other areas. In Illinois, the ISC structure fulfills the requirements for conflict-free case management. This is why the planning process switched a few years ago from service providers to the independent service coordinators. The next slide will explain CMS's concern with provider organizations being responsible for plan development. So this slide is direct language from CMS and summarizes why they are so concerned about the issue of conflict-free case management. So CMS tells us that among their concerns about service provision in the absence of conflict-free case management are that one or more of the following conflicts may arise. A provider organization may exert undue influence over goals. And so they give the example when they speak publicly. For example, if somebody wants to pursue an area or interest and the provider organization doesn't have resources to address that, they may try to direct the person towards other areas where they do have resources to assist the person. Compromised individual choice of services. Misaligned financial incentives, or provider self-referral. And the thing that I always kind of comment when we're talking about this topic is CMS is very direct and clear. They don't try to sort of couch their concerns in polite language. They're pretty direct with why they believe that services should be based upon a plan developed by somebody other than the provider. And in addition to the development of the person-centered plan, other duties CMS requires to be completed through conflict-free case management structure include assessment, service plan development, referral for services, service monitoring, and remediation of problems. So again, in Illinois, the ISC structure that we have is the conflict-free case management requirement or compliance with CMS's requirements. Before the ISCs began doing the person-centered plan, then they didn't meet the full intent of CMS's requirements. And again, those of you who are more familiar with day-to-day activities in the system would recall that about 2 years ago, that process was transitioned from provider organizations to the ISCs, and this is really the reason why. So as part of the HCBS Settings Rule, CMS required states to develop and submit a state transition plan, or STP, summarizing how the state would go about implementing the rule, including determining whether current HCBS settings complied with the rule. So basically, CMS recognized that this rule and these requirements could be transformational for some or many states, and indeed that was exactly their intent. Rather than just trust that the states would implement the rule as CMS expected, part of the rule outlined the process by which states, would assess their service delivery system and would make changes to it to comply with the rule. And that detail had to be packaged into what was called a state transition plan, or an STP. Illinois' STP is one of 6 from across the country that is still awaiting initial approval by CMS. So we can presume there is some question or concern regarding the plans that have been submitted. And I say plans in the plural because an initial plan was submitted with some feedback from CMS, some updated information was submitted. And again, we remain one of 6 states that hasn't yet received initial approval. The original compliance timeframe for the rule was 2019, but was pushed back to 2022 by the current administration, largely due to concern from states about meeting the requirements. So in Illinois, where 65% of people in SILA services live in settings of 6, 7, or 8 people, and by the way, we rank #1 in the country for the size of HCBS residential settings, not the #1 distinction we would hope for, there is some serious question about how the rule will impact service delivery. And when I'm talking about the rule, both with families, with people receiving services, and with providers of services, I always emphasize that the service delivery system that we have in Illinois, we would think that we probably have somewhat of a ways to go to meet the at least the spirit of the rule. But the system really reflects 25 to 30 years of system design, which is pretty disability specific and largely congregate. It's not that provider organizations don't agree or have been reluctant or don't want to try and provide services in a different manner, but the payment for services and the regulations governing services, really have created the system that we have today. So this is a summary from Illinois' initial survey of HCBS settings back in 2015. I'll remind you that the rule was enacted in 2014, and in 2015, HCBS settings across Illinois had to complete a self-survey, and the survey was intended to determine how close or how far away the setting was from meeting the requirements. And so you see here in the numbers 1, 2, 3, and 4, this is how our sites shook out, if you will. Based upon the survey, then Illinois identified 1,772 sites that fully align with the federal requirements. Now, the majority of these settings were IDD settings, though Settings for other waiver populations were also included in the survey, but just remember that our population is the largest waiver population, so the majority of the settings in the survey would be serving folks with IDD. And I'll just repeat, having, if you recall the previous comments about the size of our settings and the nature of them, in our initial survey, we believed that the vast majority of our sites were already fully compliant. Then we had 406 sites that we thought weren't yet compliant, but could probably comply with not too much effort. And I have to tell the tech folks, sorry, I just lost my screen. So
sorry.
She switched to view.
Yeah, we're just gonna say we lost the slide, so let's get those pulled up. If that's okay, we'll click through. Oh, thanks, Kathy. You already got it. Okay.
Sorry, yeah. The joy of technology, right?
Yeah.
To our STP second slide, sorry. And then smaller number of sites that there was concern about whether they would meet the requirements of the rule. So in total, about 92% of Illinois HCBS settings were identified as already being fully aligned with the federal requirements or pretty darn close to being aligned. And again, given the delay in the approval of our state transition plan, and as I said, knowing the nature of our HCBS system, particularly for people with IDD, that might be a little optimistic to think that this rule is not going to have significant impact on the IDD system. So let's take a look at sort of switching gears to another topic that's getting increasingly more attention. The Transitioning to Integrated and Meaningful Employment Act is a piece of federal legislation aimed at eliminating subminimum wage for all people, including people with IDD, and promoting competitive and integrated employment. So this particular piece of legislation, and again, this is at the federal level, was introduced in 2017. It has not been enacted, but remains alive today. I believe I just read that there was a hearing on it last week. And the purpose is to amend the Fair Labor Standards Act, which is where the basis for subminimum wage for work for people, again, with IDD as well as with some other conditions, is permitted. And the provisions of the bill would phase out subminimum wage over a 6-year period and include some assessment and planning requirements for people currently working at subminimum wage. Folks who are in the Chicago metro area may know that just this past week, Mayor Lightfoot announced a proposal to eliminate subminimum wages for people with IDD in Chicago in 4 years, along with an accompanying $15 an hour minimum wage. There's been some similar legislative proposals in the Illinois General Assembly within the past few sessions, but they have not yet passed. I will say, my exposure both at the state and the federal level, this topic is getting more and more attention. And again, there's an effort underway here in the Chicago, well, not the Chicago area, here in Chicago proper, to eliminate subminimum wage in the near future. So as you know, the Illinois IDD system has been subject to a consent decree called the Liggett Consent Decree since 2011. The consent decree came about in response to people living in ICFDDs who wanted access to HCBS community services. The state and plaintiffs, represented by Equip for Equality and the ACLU, eventually agreed to the provisions of this consent decree and were joined by another group representing people who wanted to remain in ICFDD settings. This group is identified as the interveners. Because of the Liggett Consent Decree, thousands of people have received community services over the past several years, and people living in ICFDDs who wanted to move out have been able to access services to do so. For the past 3 years, the independent court monitor assigned to the case has found Illinois out of compliance due to a lack of adequate investment in community services as well as the lack of an adequate quality monitoring process. A pilot project is underway right now addressing the latter issue, and we should have a report from that pilot in early 2020. Regarding rates and investment in the community system, a number of initiatives are underway. The state's FY 2020 budget included a 3.5% rate increase for community services, including ICFDDs. This was the first rate increase in over a decade, and while the FY 2020 budget took effect on July 1st of this year, the rate increase has not yet been put in place due to needing approval from our friends at CMS, which was recently granted retroactive to July 1st for HCBS programs and August 1st for ICFDDs. A notice just came out from the department on Friday afternoon for those of you who might be affiliated with a provider organization. Also related to rates, there's been a statewide committee in place for over a year working on recommendations for the state to consider in redesigning the rate. This summer, the state contracted with Navigant Consulting to develop a new rate methodology for IDD services. As part of that process, a provider survey is beginning today with an informational webinar scheduled for tomorrow morning. This data the provider survey data, I should say, will help shape Navigant's recommendations to the state. So if you are a provider organization on the webinar, be sure that you are involved in this process. And if you have no idea what I am talking about right now, reach out to me via email after the webinar, and I will make sure to get you the state's notice about this topic. It is essential that any organization that's providing services be a participant in this rate study. I will caution that it is a fairly involved financial survey, but it really will provide the basis for the state for Navigant, I should say, to be able to make important recommendations to the state on topics that will impact service delivery and resources available for IDD services. Some other topics that came out of the LIGIS Oversight Committee include recommendations in, there were 6 subcommittee areas. For those of you who are familiar with the recent assistive technology grants that the state awarded, that was one of the recommendations that came out of that committee. There's some other efforts underway that the Oversight Committee continues to discuss and take a look at. I would say that probably the most important and the biggest chunk of activity is taking place within the Navigant contract to look at rates. So we're going to actually conclude. So maybe there's a lot of questions. We're going at a fair clip here, and generally when it's a live and in-person presentation, there's a little more back and forth. But we're going to just share some information that we at the Institute have been working on, and just to give you a little bit of background on the next few slides. The SILA population, the population of people in SILA services, we can call it 11,500. It fluctuates from that. And again, while there certainly are people in intermittent and family SILAs, smaller settings, the majority of people are in what I would call group home arrangements. And as I referenced earlier, 65% of our SILA population is in settings of 6 to 8 people. So that's kind of the what the settings profile looks like. And I will say, having worked in the Illinois service delivery system since 1985, including being a direct provider of services, I felt like I had a fairly good sense of who we were serving in SILA services. I found myself sometimes in conversations with people where I wasn't so sure that the image I had in my mind of who we were serving was similar to the image they had in their mind of people we were serving. And I began to think that there was a sense that the support needs of people in SILA services were significantly different from the support needs of people in some of our other programs, and was able to kind of do some analysis on functional data that we had from the ICAP, the Inventory for Client and Agency Planning, which I can also tell people because there's been some discussion back and forth about whether that would continue to be the functional assessment tool used for people with IDD in Illinois, and the decision has indeed been made that it will. There are some efforts underway to take a look at whether there are some accompanying assessment tools that would better capture health needs or health concerns and behavioral or psychiatric support needs. Those have not yet been finalized, but the ICAP is going to remain for the foreseeable future the functional assessment tool that's used. So with the ICAP, if you're familiar with the tool, it yields a service level score, basically from 0 to 100. And that's a reflection on the degree of services and supports that a person would need. The lower the score, the more intensive the person's service and support needs are. The higher the score, the more independent and less intensive the person's need is for staff services and supports. And so we were able to look at the service score profile for people in SILA settings. And although the screen is a little tight, we'll walk you through what the current profile is for people in SILA services. That smallest slice of the pie, the sort of teal-green slice at the top, is people with the least support needs or the most independent. Moving to the right, starting at about 12 o'clock, you see 11.11% of people in SILA services have what is described by the makers of the ICAP as total care and intense supervision needs. Moving down, the next group of people, 29.5% of people currently today in SILA services have what is described as extensive care, constant supervision. For those of you who are familiar with the ICAP, those are going to be people now between those two categories who have an ICAP service level score of 39 or below. And I do say that there's not a definition in the ICAP to what constitutes total, intense, extensive, constant. But what I say is they all sound like a lot, right? If somebody has total care or extensive care, if they need intense supervision or constant supervision, that's a very staff-intensive need for the person. And related to this topic and the topics we're talking about today, we, along with every other state in the country, have a severe shortage of people working in direct support positions with people with intellectual and developmental disabilities. So to know that 40% in total of the current SILA population has needs that are described by the assessment tool as being total, intense, extensive, and constant is concerning, right? Because we are concerned about whether the workforce that we have is sufficient to adequately meet the needs of people that are presently being served. Moving around the pie, if you will, the next classification is regular care and close supervision, and then limited care and regular supervision. So while the majority of people fall within the regular, limited, or least amount of care and supervision, 40% of the population being described as having the level of need that they do per the assessment tool is something that I'm not entirely sure everybody fully understands. And so again, when I have an image in my mind of who we serve in SILA services, I worry about whether it is the same image or visual that people who maybe say in a position of legislating budgets that impact our services have. And we need to make sure that there's a uniform understanding of exactly who we are serving. The other information I'll give you relative to this slide, although it's not depicted on here, is that in addition to 40% of our population having total, intense, extensive, and constant supervision and care needs, 27% of our SILA population is age 60 and older. And again, I'm not sure that is the demographic profile that people think we are serving. And I will say again, we've been talking about this information for the past few months. I realize that in the general population, you know, as somebody who's close to it, 60 certainly is the new 40, right? And we can say that, and 60 may not sound that concerning, but I just remind us that for people with an IDD diagnosis who were born 60 years ago, they've already well surpassed their initial life expectancy. There's often co-occurring medical and health conditions. Oftentimes we see that people have been on medication regimens for, you know, practically lifelong periods, all of which really distinguishes that age factor for the people that we are serving from the general population. So 27% of our population being age 60 plus is a significant feature in my mind. The final slide I'm going to show you is not a direct comparison, but let me walk you through what we can see here. So this is two different populations. The darker bar being our SCILA population, which we just talked about, and then the light blue bar being the average service score for people living in SODCs. And that's where it's not a direct comparison because we don't have the individual ICAP scores for that population. The only publicly accessible data tells us for each facility what the average score is. And then knowing the overall population of each facility, you can calculate for the entire SODC service line where those folks fall. So again, to be clear, this is not to say that there aren't people in SODCs, state-operated developmental centers, with extensive and intensive support needs, but their number doesn't rise to the level to deflate the average score for those settings. The other thing I will remind us is that even if every single person currently living in an SODC setting fell within the intense or extensive service need, we still have 2.5 times that size living in SCILA settings with that support need. So it's not, and we're not trying to say, you know, it's not pitting one model against another, but it certainly is saying that we need to recognize that people in community settings have intensive and extensive service needs, and the resources being directed to meet those needs are dramatically less than people in settings where we can't yet demonstrate that level of support equals the level of support of people in SCILA settings. So this is some information that we are working to share and to try to start a conversation about assuring that we have equity in the service delivery system for all people with intellectual and developmental disabilities. People with intensive and extensive service needs shouldn't have to leave a community setting if that's where they choose to stay in order to get the resources that would be available to them in another setting. So this is some newer information, but I think in terms of some of the larger issues being discussed in Illinois, and you know, we do have limited resources, and we do have competition for those resources and legitimate competition. There's other service populations, there's other needs that the state has, and really we're trying to look at how do we assure the best use of limited public dollars. And you know, starting with knowing who we're serving and where they're at, I think is an important first step, rather than I think the presumptions that have been in place for the past several years about who we are serving. We now can really profile and define who we're serving better, and start a conversation about how do we assure that those people are getting access to the services that, again, would be available to them if they lived in a different setting. And with that, I am more than happy to respond to any questions or have some further conversation if there is anything that we've talked about so far. If there's topics that we didn't address, to the extent that I have anything to comment on them, I'm more than happy to share what I know is taking place across the state.
All right, thank you so much, Kathy. That was a wonderful presentation. Just as a reminder to folks, you can write in any questions you may have in the chat box area. Our moderators on our end will also field questions if we get them from other people who wrote them separately or anything. But so feel free to type those into the chat box if you have any questions for Kathy. And in the meantime, I can start you off with one that we received, which is what will happen if some Illinois settings don't meet the new settings rule requirements?
So that is part of what the state has to address in our state transition plan, is that very possibility. And per the rule, the state would be required to offer people opportunities to receive services in other settings that do indeed comply. So CMS isn't saying that if somebody happens to be receiving services in a setting that doesn't meet the requirements, that they no longer would get services. What CMS is saying is that the state has to assure that there are other options available for the person. And I would expect we would probably see the ISC structure involved in that. We haven't really reached that point yet, but I would imagine that the ISCs would play a role once a determination has been made. Let me be clear, the ISCs don't make the determination about whether a setting complies, the state does. But if it was determined that a setting did indeed not comply, I would expect the ISCs would likely have some involvement in trying to help people identify other programs or other opportunities that would meet the requirements where they could transition to.
All right, great, thank you. Another question that we have gotten is if the Navigant rates study recommends increasing rates, where will the money come from?
Yes, so that's a logical question to ask. Navigant will be making recommendations to the state. I would imagine that we will see some recommendations for increases, right? Because it defies logic that reimbursement, for example, for DSPs, now it's being addressed by the state, but in Chicago will only be at minimum wage. And we all acknowledge that these are not minimum wage jobs. So nursing, for example, is another component of the rate where we have irrefutable evidence that the reimbursement is well below the Department of Labor, Bureau of Labor Statistics wages for nurses. So we would expect that we'll see some recommendations that would talk about increasing rates. I don't know, I can't conceive of any, but I suppose there could be recommendations to decrease rates. And what really happens then is that will not magically produce the money to go ahead and implement the recommendations. I've kind of said that gives us who are interested in the IDD service delivery system and committed to improving services and quality, that gives us a tool to use in our efforts for advocating with the General Assembly and the state to either increase resources or redirect resources. And redirecting is certainly something that I think would be having some conversation about. And really, you know, for folks, sort of preparation, I mean, that's really where the focus is. I mean, the Department of Human Services doesn't independently determine, you know, how much money they get to spend each year, right? It's appropriated as part of the state's overall budget. So, you know, they will benefit from our efforts to advocate, and the Navigant rate study will give us, I think, an important tool to use in those efforts.
All right, thank you, Kathy. Let's see. Someone said, I'm surprised that people in community settings have similar or greater needs than people in state institutions. What accounts for this?
Indeed, I think a lot of people are surprised. And that's that addresses one of the reasons that we undertook this effort, is that I think there is a an inaccurate perception of who we're serving. One of the things, and I can't say categorically for every person, but until the latest consent decree, it was difficult to get somebody into a group home setting or to get approval for SILA services, right? So, to some degree, the population that began in SILA, many of those people have aged in place in their SILA settings and now constitute that 27% of older people. And with that, there's going to be some accompanying functional decline. I think over the years, we had people in emergency circumstances who were able to access SILA services. And I don't have data to support this, but again, it's, I've been in Illinois since 1985. I have a fair sense of who we're serving and how they got there. Folks who came into the SILA service system, through the emergency pathway, it's conceivable that they had more significant support needs, and that's what put them into that category, because their families could no longer care for them based on their level of support. Over the past several years, then as families have been able to access services, many have chosen, we know this statistically, many have chosen the home-based program. And I don't have functional data to compare the ICAP scores between home-based and the SILA population. But I would venture a guess that we would find that home-based population is more likely to be in that middle category of the service level score, sort of the regular support and supervision, and maybe a little less likely to be in the intensive and extensive classifications.
Okay, thank you. And then, so Marie just typed, is the DHS/DDD update and Q&A webinar tomorrow at 11 the one that you referenced earlier?
I don't think so. That sounds like perhaps the ARC of Illinois is hosting a webinar that I think I have seen evidence of. So the one that I am referencing is being conducted by the folks at Navigant. If I attempted to pull it up on my screen right now, I'm sure I would just lose all of you. So I can't do that for you. But technology is. I prefer live and in person, but we'll leave it at that. You see my email at the bottom of the screen if anybody is interested in the notice about the rate provider rate study survey webinar. I think that's what it's called. That's tomorrow. Just go ahead and shoot me an email after this, and I'll send you the attachment. And I'm sure the ARC webinar will be highly informative as well. So but I believe is a different topic. I believe that's the one that has court monitor on it, has our new director Allison Stark on it, and maybe one or two other people.
Okay, great. Thank you. It seems like a lot of good webinars out there. So as Kathy said, her contact information is at the bottom of this slide. Feel free to contact her. We would also like to remind you that you can download handouts of this presentation. So, if you didn't get a screenshot or didn't jot down her information, you can access these handouts at the same place you registered for the slides. And that will have this slide on it, so you can get Kathy's contact information there as well if you want to go back and look for it. Do you have any other questions for the group?
Nope, I do not. I appreciate people's time and attention, and hope you walked away learning at least something new or answered some question that you came into the webinar with.
All right. Well, thank you so much again, Kathy. Our next slide was just, again, asking if folks had questions. But we would like to share with you that our next webinar is going to be on November 20th from 12 to 1 p.m. Central Standard Time. and it's titled Psychopharmacology of Autism Spectrum Disorder, and it will be presented by Dr. Fedra Najjar. And you can register at this link on this slide. So again, if you're having trouble finding the registration link, you are welcome to download these slides or handouts where you will be able to just click on the link, or you could just type it into your web browser. So that is all we have for you today. So thank you everyone so much for joining us, and we hope that you can join us for another webinar again soon. And thank you again to our wonderful presenter, Kathy, and also to our captioner.
Thank you.